All right, good morning, everyone. This is Christine Brown, Director of Member Engagement here at the Reno Sparks Chamber. Do we have Dr. Schwenk on the line already? Looks like perhaps we're still waiting for the good doctor, so we'll give it a couple minutes. Just a quick reminder to everyone. Oh, hi, there you are. How are you, doctor?
Good morning.
Good to see you. Just a quick reminder to everyone on the call, just go ahead and mute your lines for us if you could, to keep those barking dogs down to a minimum, as we're also used to now at these Zoom calls. As much as we love our four-legged friends, it's probably better that we don't hear from them today, so we can focus on the matters at hand. Once again, it's a pleasure to welcome you all here. This is part of our new Chamber EDU workshop and webinar series, and perhaps you've seen some emails about both of these offerings that we have at the Chamber this fall. We've got a combination of workshops that we're offering, which include in-person instruction and also an online component, and then we also have these quote-unquote extra credit webinars that are free to members, of course, and we're happy to offer those. We're covering lots of different disciplines over the next couple of weeks, and so I hope that you will keep your eyes peeled on your email and also our website to see when and what those webinars will be. But for today, again, it's my pleasure to welcome back Dr. Thomas Schwenk. He's the Dean of the UNR School of Medicine, and he's here to give us some updates on COVID-19 in our community, and also what the university's role is in COVID-19 response. So Dr. Schwenk, welcome once again.
Great to be with you again.
All right, thank you. We'll just go ahead and jump right in. Also, just another reminder, if you have any questions for Dr. Schwenk during the call, go ahead and use Zoom chat, and we will go ahead and address those questions as we are able at the end of the call. All right, let's jump in. So doctor, it's been about 6 to 8 weeks since we last saw you. We're at a pretty good click seeing you about every 6 to 8 weeks now. What kinds of updates can you give us when it comes to COVID-19 response and the prevalence of the disease here in Washoe County?
Well, you know, Christine, there's really nothing happening. I don't really have a lot of news. It's been kind of a slow news cycle, don't you think?
Not a whole lot going on, no.
Let me just touch on a few things, and maybe you can pick off some secondary questions if you want from that. With regard to the national numbers as a whole, I think what you're seeing is an uptick in many states, perhaps more than half the states. Nevada is one of those, with a little bit of a bump here and there. I think what you're seeing is the disease working its way through the population. A commentator recently used a good analogy, which is this isn't like a hurricane where it comes and hits and lasts for a day and then moves on. This is like a forest fire. And of course, in California and Nevada, that's a particularly good analogy. But it just sort of burns its way through the population unless there's an absolute complete isolation and shutdown. And of course, that's difficult to do. I think we were on the downslope in many large cities, and then it moved out into smaller towns, moved out into smaller communities. You're seeing a lot more in the Midwest, for example, the upper Midwest, the Dakotas, Wisconsin, Minneapolis, Minnesota, and you're seeing it in other states as well. I think the opening of school has probably contributed to that. The opening of universities has contributed to that. Certainly the case in Reno that we've had an uptick in the number of reports on the UNR campus. Whether that actually contributes to the spread through the community is a little harder to say and a little harder to track. I think you saw some controversy with regard to both the Northern Nevada Health Department and the Southern Nevada Health District, and the fact that they felt left out of some of the recent decisions by the governor to open up to larger groups and to possibly open up to conventions up to, I think, 1,000 with various types of restrictions. What I'm seeing, at least, is some continued tension between some of the numbers with regard to infection, the fact that deaths continue at many hundreds a day, sometimes creeping up to higher hundreds per day across the country. And the numbers just keep grinding along, and different states are doing different things, and states come and go, and cities come and go, and schools come and go, and universities come and go. So we've settled into what is probably a kind of an enduring, consistent grinding of infection as it just kind of plows through different segments of the population. The epidemiology has changed, as you know. The age of patients has dropped, and that's because most older patients have already been exposed or infected, or they are completely isolated, and it's younger populations that are more exposed, more out into the community and out into the business sector and the universities and that sort of thing. So that the age of the infections is dropping, and because of that, the fatality rate is dropping. But I guess one thing I would emphasize is this is not totally a disease of old people and not totally a disease of people with underlying condition. There are many notable reports of younger people who have been infected and some died. So some of your other questions get into other aspects of this, but that's an overview.
Right, absolutely. Just quickly, it struck me as you were speaking. We, at least in Nevada, some of the metrics we've been paying attention to closely, or at least we've been told we're paying attention to closely when it comes to whether or not we're going to make determinations to reopen different sectors of the economy, reopen schools, et cetera. We've been looking at hospitalizations. We've been looking at the positivity rate. Have you seen any concerns when it comes to which statistics we're focusing on? And do you think that we're kind of missing the forest for the trees and not looking at the right metrics when we're making our decisions?
Well, to extend the forest fire analogy, I think your analogy is very good, the forest for the trees issue. I think the problem is this: all of us, all human beings would like to have hard, objective thresholds and numbers. And we'd like to have numbers that says when you get to this point, certain things happen. When you get below this point, certain things happen. And that's really impossible to do here. And the reason is, again, because the infection is kind of moving its way around. It kind of picks off different communities, different hotspots. Cheryl Hug English, the director of the Student Health Center, who's the main advisor to the UNR president, formerly President Johnson, now President Sandoval, is pushed all the time about numbers. How many cases, what positivity rate? And she said there really are no good thresholds. It's more a matter of how do you kind of keep a lid on the infection just kind of plowing through the community versus keeping the community functional, keeping schools functional, keeping universities functional, keeping business functional. And that's a very subjective call. And so I get the fact that politicians have a lot of difficulty. I have great empathy for them, including our governor, for making difficult decisions, because there really are not hard numbers. You see certain, positivity rates, but that of course depends on how many tests and what kind of tests you're doing and in what populations. Then you see fatality rates, and those are going down, except the denominator's going up. So the total number of deaths continues to kind of plow along, even though the fatality rate itself is lower. The absolute number of deaths is still pretty persistent and consistent. And of course, all of this is coming into the fall when we assume that this is going to get worse. So I think your question is spot on. It's just impossible to answer.
Right. Absolutely. And shifting attention to the fall, I know last time we spoke, we were essentially preparing ourselves for a pretty particularly rough season when it comes to the interaction and interplay between COVID-19 and the seasonal flu. Have we started to see the effects of both of those diseases in concert in our population yet? And if so, what have some of those effects been?
I don't think we've seen enough to know what's going to happen just yet.
Sure.
We are pushing very hard on flu vaccine. That would be the single biggest message I would leave with this group, is that you need to be advocates, you need to be proponents with your employees and your colleagues and your business associates. The flu vaccine is more important than ever, because we cannot stand a huge flu explosion at the same time we expect COVID to pick up. There's not a lot of known interaction, although that's being looked at a little bit, whether flu vaccine enhances immunity and that helps with COVID, or some people suggest that somehow having a flu vaccine or having the flu somehow detracts from your immunity. I don't think we have any data about that. But we don't really know yet what the interaction will be. What we do know is that even if there's no interaction and you get parallel tracks of two major diseases, the healthcare system is going to be overwhelmed, and that's going to be a major issue. It's not clear how the virus behaves yet, how the coronavirus behaves in the fall. Most respiratory viruses in general go up. People move indoors, transmission increases, so that's the generally accepted notion. It's not clear that that's how coronavirus behaves necessarily. So we don't know, but we are anxious, and you've heard from all the national experts, far smarter than I am about this, that they're really worried about this.
Right, absolutely. No, I agree. I think it's too soon to tell. And another thing that's likely too soon to tell is, what kinds of impacts we're going to be seeing now that Nevada's gathering restrictions have loosened somewhat, which you briefly touched on in your first response. But I wanted to circle back to that. How we know that generally speaking, we have to wait about 10 to 14 days in order to see the effects of some of these shifts. Good examples are Labor Day gatherings, holiday gatherings, 4th of July, Memorial Day. We saw spikes about 2 weeks after those particular events. When do you think we're going to start to see the effects of loosening gathering restrictions? And what do you think those effects are going to be?
Well, we're certainly going to be watching closely. And as you say, there's a little bit of a lag time, and we're always looking. We know for a fact that during various one-off events, family reunions and funerals and other activities in which people were not protected, that there have definitely been spikes after that. We know that when we opened schools and universities, there were spikes that came after that. So we expect that if gatherings are, the restrictions on gatherings are loosened and we get larger gatherings or conventions or sub-conventions, the way the governor sort of laid out the restrictions of different rooms with pockets of people. Right. We assume that there's going to be a bump, but that just takes us back to the fact that we know for a fact that masking and appropriate hand washing and distancing is effective. We know for an absolute fact. And I can't tell you how annoyed I get in the occasional foray that I have into the community to see people just refusing to mask and denying the importance of this. And it just upsets me so much because of the known public health expertise and the common good approach. So what I would say is that I'm guessing that the governor's fine loosening restrictions on group size if people would just do what they're supposed to do. And we might be okay. Most of the outbreaks that we've seen after some of the family events have really been because they've been unmasked and been too close. So it's probably very possible to have an event of 250 people if people would just do the right thing. But so far, we've not found that to be the case. And I'll just mention my hugest pet peeve, which is people with masks below their nose. Oh. It just drives me nuts. Right. And I just kind of want to say, do you think you don't breathe through your nose, or that there's something special about your nose that should be left off of the mask? It just makes me crazy.
Oh, goodness. Pet peeves we never thought would be pet peeves for us.
That's right.
This is our life now. So kind of turning attention to arguably one of the most talked about breaking news items in the last week, President Trump's COVID-19 diagnosis. Politics aside, I think one of the fascinating elements to watching this situation unfold is actually getting a view into some of the new therapeutics that that were used in the president's treatment and are being used in the president's treatment. I'm curious to hear from your perspective, about some of these therapeutics that have been used in the president's care, what some of the new developments have been. I know that there were a couple things that I hadn't heard of that were being used in his treatment. Could you speak to that?
Well, I knew you'd get there eventually, Christine. So let me say this. I'm going to speak strictly medically.
Yes.
As a medical professional, no politics. These aren't political statements, but I'm going to say some things that I suppose some people could find offensive. But I'm just speaking strictly as a physician in the way I would hope all physicians would speak. I think that the president's illness and the way it was managed has really done a great disservice to people's understanding of science and understanding of how this disease should be assessed and how this disease should be managed. So here's the fundamental issue. The drugs that were used, dexamethasone, remdesivir, and the polyclonal sort of cocktail of monoclonal antibodies that were used, none of those have been studied in the phase of disease that we believe the president to have had. And that, of course, have caused all the commentators to say, well, maybe the disease is more severe. And as best I can tell from all that I've read and followed, I don't think that the disease was that severe. I just think they used everything that we have in our armamentarium and threw it at the president all at once. Remdesivir has been studied only in hospitalized patients with severe disease, and it shortens the disease a few days. It's not clear whether it changes mortality, but it may shorten the symptoms a bit. But again, only in patients who were hospitalized for severe disease. Dexamethasone is used in even more severely affected patients who are hospitalized. It's a steroid, and it reduces the inflammatory hit that the COVID disease seems to cause. And that's not been used in patients with this level of disease. And the polyclonal antibodies haven't been studied at all. So we have no idea where those might be used. Dr. Fauci and others talked a lot about how we don't know what happens with the combination of drugs. I'm not too concerned about that. They all work in different ways, and there's probably not obvious interactions that will take place there. What I am concerned about is that when you throw everything at somebody at an early stage of the disease, they seem to get better. And then we know that the real dangerous time is 6, 7, 8, 10 days out, which is coming up later this week and into the weekend. What happens if there's a rebound? What happens if the immune reaction floods in, as it does in some patients, and you've already used your 5 days of dexamethasone? Do you go back on dexamethasone? Remdesivir, you probably would, because if the patient was more severely affected and came back in the hospital, you'd probably try it again. We know nothing about the monoclonal antibodies in that regard. So you're sort of stuck at that point. Here's the reality. All of us use many drugs in what's called an off-label way. Off-label means that there's nothing in the FDA-approved label that says this drug has been tested and worked. But we use these drugs. Half of what we do is off-label because we're using known drugs that have had long experience, tons of studies, lots of data. It just never found its way to the FDA to get a label that says it's approved. So we use off-label stuff all the time. So I understand the desire to throw the remdesivir and the dexamethasone at the president's illness, and I think because you're dealing with high stakes issues here, I get that. The problem is it's not a matter of just off-label, it's a matter of no data. So it's one thing to use drugs somewhat differently when you have lots of data. Here we have no data at all, and I do worry about the blowback.
Right.
I will just say, in the sake of complete transparency, that I think many in the medical profession have been appropriately critical of the White House physician and how the communication was handled. That is not our job as physicians. I'll just tell you that straight out. Our job is to represent the patient, represent the medical facts. It's not to be a cheerleader. Right. And so I think that's done the public a disservice to really understand how sick the president was and some accurate reporting. I get the fact that there are HIPAA issues and that you only should be required to report certain things, but I think there should be a bias toward transparency because this is not just one of us getting sick. This is the president, and I think we deserve to get an accurate picture. And the problem when you don't get an accurate picture is then you don't know what happens next. So what happens if if the president gets sick again and goes back in the hospital? We're not going to know, where we were and therefore where we are. So just being completely transparent. I hope it's not offensive to anybody.
No, thank you for being candid. And, it's interesting, as you were speaking, I remembered our last conversation in which we were talking about specifically about therapeutics and how they're being used right now. And something that struck me as I was thinking about this scenario with the president, receiving multiple therapeutics all at once in a flood, almost that visual of, throwing everything at the wall to see what sticks. You mentioned in our last conversation that there's so little way of knowing the efficacy of certain therapeutics when, one, they're all being used in concert. Who's to say which one is having the most effect or the best effect? So we're kind of shooting ourselves in the foot when it comes to really knowing what is effective in fighting this disease. But we're preventing ourselves from accumulating the kinds of data that would allow us to make informed decisions in the future. And so it's just the unfortunate reality of dealing with a disease in real time that we're trying to save lives while also trying to acquire enough data in order to fight and hopefully one day eradicate the disease in the future. So it's a very interesting real-time situation we're finding ourselves in that's presenting itself with a lot of difficulties. But thank you very much for your honesty.
I think it would have been perfectly fine if the medical team came out and said, look, the president was diagnosed on this day. The next day, there were 2 episodes of a drop in oxygen saturation. We were very anxious about where this was headed. We studied the literature very carefully. We understand how these drugs were used in a different type of patient. We felt that it was justified to do this for this reason, to do this for this reason, to do this for this reason. I think people would have said, fine, we totally get that. We understand that that's probably not the care I would get if I went in the hospital, but we get why that's the care the president gets. I think that's all they had to do. I don't know why we got ourselves so twisted up here and so much political and medical controversy for something that is actually fairly easy to talk about.
Right. Thank you for being straightforward and thank you for sharing your medical opinion on that particular situation. So shifting to a vaccine, that's what everyone is continuing to talk about. That even though we know masking, social distancing, these things have profound efficacy and proven efficacy, we are still waiting and hopeful for that vaccine. What's your best guess on a timeline for an effective vaccine? I know we're hearing a lot of different theories, a lot of different opinions. What is yours?
I think you'll see some sporadic use of something before the end of the calendar year, but it will be well into the next year before there'll be widespread use and widespread availability. So you're going to see that whatever comes out, it sort of administered in waves of healthcare workers, other essential workers, other high-risk patients. You kind of move through the population, eventually get to the broad swath of the population. You have to remember that despite all the infection going on, all the exposure going on, all the deaths that have occurred, the immunity rate in the population is only about 10, 12% in most communities, a little higher in some, lower in others. And so despite all this exposure, the natural immunity is only about 10% of the population. So we've got a lot to go in terms of vaccine immunity. What I would encourage you to look for are a few of the following things. There are at least 5 or 6 candidates in play right now, and they target different approaches to the vaccine. So some look at the spike, the protein that makes the spike, because that's what attaches to the cell that causes the damage. So there's a vaccine that looks at the spike protein or looks at the place where the spike attaches. There's a vaccine that actually kind of takes the whole virus and knocks it down so it's not infective, and then incorporates it into another virus and tries to take the whole virus into the body. There's a vaccine that looks at the RNA that's inside the virus, because that's actually what's infective and that's actually what does the damage. And so trying to attack that. And there are a couple of versions of each of those. So you're going to see different vaccines. I think what's going to be interesting is that it's likely that more than one will work. And it's likely that more than one of a different approach will work.
Sure.
And so it's possible you'd end up taking different vaccines. It's possible you take 2 different vaccines, perhaps. And maybe both of them have double doses. So you do one vaccine, and a month later you do another vaccine, and another month later you do the first vaccine again, and another month after that you do the second vaccine again. That's very possible. So that takes time to play out. The other thing I would comment on is following the studies. The problem with vaccine studies is that you have to have huge numbers of patients in order for a relatively small number of patients to get infected, so as to show that a lesser number of patients got infected if they got the vaccine. So when you're doing a drug trial for a disease, you can pick 100 people who have the disease and give them the drug, and 100 people who have the disease and give them a placebo, and you can tell really fast what the effect on the disease is. But if you want to get 100 people with COVID, you need to have 20,000 vaccinated to understand who's going to actually get exposed. And then, of course, there's the problem that you might pick patients from areas that are low prevalence that aren't very likely to get the disease in the first place. And so your numbers are even worse. So when you start reading about this in the next couple of months, what you're going to see is studies in which tens of thousands of patients were given the vaccine or given a placebo. And out of that, maybe 100 got the disease if they got the placebo, and 50 got the disease if they got the vaccine. And we're going to base all of our decision-making for 330 million people on whether 50 people got the disease or didn't get the disease. So just keep that in mind. They're really hard studies to do. Vaccine studies are the hardest. There are diseases that took 15 years, 20 years, 30 years, 40 years to develop a vaccine because it was so difficult to do the studies. And there are some diseases that never actually made themselves amenable to having a vaccine. So it's a very complicated field.
Right, absolutely. And are there I know the university has been involved in studies related to convalescent plasma. And I'd love to hear an update on that actually here in a second. But first, are there any plans for the university to be involved in clinical research when it comes to a vaccine?
Yeah, we actually have applied to be a site for one of, I can't remember which one, for one of the vaccines, and we hope to be selected. For better or worse, Nevada has numbers that would suggest that we would be a good place to have the vaccine. So I think that's likely it will be selected as one of the sites as they come along. We are still involved in the convalescent plasma study. That study is ongoing. It's become a little harder to do because, as you recall, there was emergency use authorization for convalescent plasma. And so that makes it harder to study because once it's available for general use, people say, well, I don't want to go into a study. I want the plasma. Right. And so that makes it a little more difficult. We're also doing a study of our healthcare workers to track them longitudinally because we want to understand what happens longitudinally to healthcare workers, to frontline workers, both staff and clinicians. So we have that underway. We're collaborating with the VA on a study of some specialized treatments for COVID patients. So there are a number of good things happening, I would say, that contribute to the science here.
Excellent. Well, we're closing in on the end of our call. And so, if anyone has any questions for Dr. Schwenk, go ahead and fire those away. I see that there is one quick question, which is actually related to the chamber. And it's whether or not there's a plan to have a flu vaccine clinic sponsored by the chamber this year. And what I'll tell everyone on the call is that right now there are no plans, but that is something I will absolutely look into. As we're looking at our new space that we're moving into next month, it does give us, access potentially to the Reno Sparks Convention Center, and that could be a possible location where we might be able to entertain a flu vaccine clinic. But that is something that I will absolutely check into, and I will connect with you, our members, on that if we end up developing something. So thank you for that question and that suggestion. I'm not seeing any other questions. Doctor, I don't know if you are, if any were sent to you privately, but it looks like there are no further questions. But do you have any closing comments for us?
Well, what I wanted to mention that there are other exciting things going on at the medical school besides COVID.
Yes, absolutely. Please
In the
share.
middle of everything, while people are thinking of questions or while we wrap up, I just wanted to mention that we continue in our very intense, very comprehensive discussions with Renown about creating a new academic health system.
Right.
And we're using that phrase specifically. Sometimes we talk about an academic medical center, but this actually extends beyond a facility. It extends to a whole health system that it's focused on teaching and research and training new practitioners and conducting new research and developing new high-end subspecialty programs. That's what an academic health system does. And those discussions are really intense. I mean, our people and Renown's staff are just putting, hundreds and hundreds of person hours into this work. We have an excellent consulting group that's helping us, and we hope to have a much more detailed, definitive agreement that will start to be shared with the Renown board in December, with the Board of Regents in December, and then on into January and February. So far, the discussions have been very fruitful, very productive. I think this has the potential to be transformative to the medical community in Reno and Sparks and across the Northern Nevada metropolitan area. And that's why we're doing this ultimately. It's really not about the school or about Renown, it's about what's right for the community.
Right.
But we're talking about things that could actually cause the access and the quantity and quality of healthcare in Reno and Sparks to just explode.
That is probably the best possible news that we could hear and that we could end on. Absolutely. Yeah. If there's anything that's clear, it's that we need to do whatever we can to buffer that pipeline between our educational sector and our healthcare sector in order to ensure that there are qualified and compassionate physicians, well-trained physicians coming into the community, into Northern Nevada to serve here, to stay here and practice medicine here. And I applaud you and all of your efforts to buffer that pipeline and to create a much brighter future for healthcare in Northern Nevada. Thank you so much.
Good. Thank you all.
All right. Everyone have a wonderful day. And of course, if you need anything, don't hesitate to reach out to me. And if you have any questions after the fact, please email me. I'd be happy to pass them along to Dr. Schwenk and get them answered for you. So,
absolutely.
All right. Thanks for joining us, everyone. Have a good day.
Thanks, Christine.
Thank you.